One of the challenges in immunotherapy response prediction in general is that it's a complicated tumor-immune interaction. And traditionally we focused on using single biomarkers, so PD-L1, EGFR, KRAS, etc. And what we're seeing is that the relationship between those features and response is complicated, and it's probably multifactorial. And in particular in KRAS, there's been a lot of focus on trying to understand whether certain single genes like STK11 and KEAP1 influence response, but the reality is that those genes also relate to other predictive features such as PD-L1. So we know STK11 associates with low PD-L1, so when we see a negative association, is that the PD-L1 or the STK11? So the hope in our project was that if we built a big enough cohort of KRAS mutant lung cancer patients, that we could apply machine learning and kind of integrate all of those variables together to understand what are the drivers of response. So for this project, we gathered our institutional cohort of IO-treated patients, and then we also collaborated with Memorial Sloan Kettering and the Dana-Farber, and so in the end we actually had over 3,000 patients with full clinical annotations and quite a bit of genomic detail as well. And then we kind of ran the data through several different models to try to understand what was driving these features. I think what we see is that even with these big cohorts and with these machine learning models, at the end of the day, we're not able to be strongly predictive. So our models, even in the best case scenario, have an AUC of something like 0.7, which is better than chance, which would be 0.5, but it's certainly not where we need to be to make clinical decisions. But part of what we're interested in is not just how predictive our model is, but what are the features that emerge, and can that help us pick IO monotherapy versus IO chemo. And in that instance, what we found is that certain single gene features within these model systems, so ATM, seem to associate with better outcomes if we give immunotherapy with chemotherapy. And we actually showed that in a separate analysis last year as well. And what we also found is that STK11 on its own didn't seem to be as predictive. So STK11 in the context of a KEAP1 alteration is very bad. STK11 on its own in the context of this model, not as strong a driver as we were thinking.